Hello everyone, very good morning to all. So it's a very special Sunday morning. So welcome all of you to this Physiology Rapid Revision session. So we call it as Achhi Tarah Padho. So this is the equivalent of NEET PG one-shot sessions conducted by DBMCI. For the FMGE wing, especially for FMGE students, we are conducting these ATP sessions. This is going to be a high-yield rapid revision session for you. So just before your exams, for all the subjects, we are going to give you a thorough rapid revision. So that is going to be of immense helpful for you. So let's join in for the first session of physiology with this beautiful quote. Never get upset, always get up and set yourself. Yes, with that, let's move on to the physiology sessions. So first of all, I would like to give you the information about what are all the important repeated topics which are asked in physiology. So that is very, very important because during the last 1 or 2 months, you cannot spend all the time for reading everything and revising all that comes in your way. You have very short period for your exams. So within that period, you should know your strategy of revising only high yield topics, especially PYQs. Please do not go to the exam without knowing answer for all the PYQs. At least for the last 4 to 5 years of question papers, you should be able to know all the answers. Not only the previously asked questions, but the previously asked topics are also very important. So I have made a list of topics which are like must know topics in physiology. So let me show you that. So let's start off with the central nervous system, the nerve physiology and the central nervous system. In CNS, membrane potentials, very, very important topic. Repeatedly, you can see questions from membrane potentials. Yes, we are all connected in the chat box. If you have any queries, I think the audio visuals are all fine. You have any queries, you can connect to me in the chat box. Yes. Any of the participants, can you just say a hi so that I'll know that you are in pace? Can anybody just say a hi in the chat box? Yes, are we all connected? Hello, Dr. Daksh Kumar. Thank you so much for that. Yes, so I think the audio visuals are fine. Amod, Siddhi, thank you. Happy morning. Sahana Bhaskaran, hi. Yes, so in case there's any trouble with audio visuals or anything, you can connect to me in the chat box. Or any questions if I ask you want me to answer also, we can come back in the chat box. Thank you. So these are the high yield topics in CNS. Membrane potential, very, very important topic. Repeatedly, we see questions from membrane potential. Nerve fiber classification, yes, again, very important topic. Nerve injuries, vision, visual pathway in physiology and also in ophthalmology, very important topic. Auditory pathway, hypothalamus, sensory receptors and synapses, reflexes, cerebellum, sleep and EEG waves, lobes of the cerebrum, neurotransmitters, Brodmann area numbers, thalamus, spinal cord, the tracts of spinal cord, UMN, LMN differences, Brown-Sequard syndrome, aphasia, neuronal facilitation inhibition, Clostridium botulinum and Clostridium tetani, medulla, basal ganglia, and stroke. So these are some of the high yield topics. Over to general physiology. In general physiology, cell junctions are very important. Homeostasis, feedback mechanisms, body fluid, the Darrow-Yannet diagram, transport mechanism across the cell membrane, cell cycle, cell division, ion transport. And from endocrinology, ADH and aldosterone, very, very important topics. So just, you can just see that whether you have revised and learned all these topics. ADH, aldosterone, very, very important. Both hormones starting with A, you will get confused with the functions. Thyroid, acromegaly, second messengers, oxytocin, obesity and appetite, Cushing syndrome, vitamins A, B, D especially, hypothalamus, hormone receptors, spermatogenesis, gonadotrophins, adrenal insufficiency, testosterone, estrogen and HCG, calcium, rickets and insulin. Over to CVS, cardiovascular system, baroreceptors and BP regulation. Very, very important. Baroreceptors and BP. Cardiac cycle, cardiac reflexes, pressure volume loop, exercise physiology, and again JVP. Consequently, we are seeing questions from JVP, pulse, fetal circulation, shock, blood grouping, heart failure, heart sounds, postural hypotension. These are important topics from cardiovascular system. Respiratory physiology, VQ ratio, pneumothorax, acid-base balance. In acid-base balance, you will get questions in physiology, biochemistry, as well as medicine. Periodic breathing, hypoxia, very important. Last year, we had a question on hypoxia. ODC curve, very, very important. Last year, we had a question on ODC curve. High altitude and deep sea physiology, again, very important. Pneumoconiosis, COPD, important. Pulmonary function tests, regulation of respiration, ciliary motility disorders, mechanics of breathing, and dead space. So these are all the topics that you must read before going to your exam. And last, renal physiology, GFR, very important. Last year we had a question on GFR. Yes, glucose transporters, we had a question last year. Anion gap, renal transplant, anemia and renal failure, tubular transport, very important. Nephrotic syndrome and clearance. So we have discussed almost all the important systems and the high yield topics, must revise topics just before your exams. And the other thing, those who are attending this session, don't worry about taking notes. Yes, Sahana, Bhaskaran, Siddhi, Amod, don't worry about writing the notes, because after the class, I'll share this complete PDF with you. The annotated slides, I'll share it with you. So it will be easy for you to go through the notes. So don't worry about writing it down. Don't write anything down. Just listen to the class. I want you to focus on the concepts, not on writing. At the end of this session, I'll share you the entire annotated PDF. So don't worry about that. Just listen to the class. Yes, let's move on to the first topic, nerve physiology. So in nerve physiology, first of all, the basic structural unit of the nervous system is called as the neuron. So what you see here is a neuron. What is the function of neuron? When someone is touching you, who is telling you that it is a touch sensation? You have a touch neuron which will carry the impulse into your brain. When someone is slapping you, now it is not touch, it is painful to you. Who's telling that it is pain? You have a pain neuron which will carry this pain. So what is the basic function of neurons? They are all carrying informations into your brain. Apart from neuron, are there any other cell types present in the nervous system? Yes, all of you, can you just type in the chat box? Do you know any other cell present in the nervous system? Apart from this neuron, do you know any other name of a cell? Anybody? In your brain and spinal cord, do you know the name of any other cell? Yes. Glial cell, excellent. Glial cell, astrocytes, very good. Dheeraj, very good. Siddhi, Swatika, Swastik, that is glial cells, very important. Glial cells. So let's learn about the glial cells. Glial cells are of two types, microglial cell and macroglial cells. So this is the microglial cell or the microglia. What is the important function of microglia? Microglial cells, they play an important role in phagocytosis. If any cell is doing phagocytosis, then it is helping you in immunity, immune mechanisms. Any cell which does phagocytosis is a macrophage. So it is a macrophage. The macrophage of the nervous system is called as microglia. This is a macrophage. This is about the microglial cells. The other group is called macroglia. Macroglial cells. Macroglial cells are of three types. Number one, oligodendrocyte. Oligodendrocyte. Number two, squamous cells. Squamous cells. And number three, astrocytes. You just have to know their functions. Oligodendrocyte and squamous cell both have common function of myelination. Both help in forming myelination. But what is the difference? Oligodendrocytes help in myelination of CNS, central nervous system, whereas squamous cells help in myelination of PNS, peripheral nervous system. That's the difference. Astrocytes. As you can see in this image, astrology means star. So they are all star-shaped cells. They are very closely attached to this blood vessel. And this blood vessel goes into the brain. So what is the function of astrocyte? Blood-brain barrier. They help in formation of blood-brain barrier. The other function of astrocyte is it can convert glutamate into glutamine with the help of enzyme called glutamine synthase. Glutamine synthase. So what is the clinical importance of this? If there is any deficiency of this enzyme glutamine synthase, glutamate is not converted to glutamine. Therefore, accumulation of glutamate. Glutamate is the major excitatory neurotransmitter. Excellent, Dheeraj. Glutamate is the major excitatory neurotransmitter. So it will excite your neurons, that will excite your muscles, whole body will be excited. So the patient will start doing like this. What is that called? Fits, seizure, whole body is excited. So this results in seizure or epilepsy. Seizure, fits or epilepsy. So that those are relevant points about astrocytes. Over to myelination and the clinical importance. Myelination in CNS is by oligodendrocytes, and these oligodendrocytes require a protein called myelin basic protein. Why do we want to know this? Autoantibodies against myelin basic protein results in a disease called multiple sclerosis. So what is MS multiple sclerosis? It's an autoimmune disorder where the patient has autoantibodies against the myelin basic protein. Peripheral nervous system. Schwann cells form myelination and Schwann cells require protein 0 and PMP22. PMP stands for peripheral myelinating protein 22. And if any patient has autoantibodies against this protein 0 or PMP22, we call the disease as Guillain-Barré syndrome. If the patient has genetic mutations of these proteins, Charcot-Marie-Tooth disease. To summarize, multiple sclerosis is a central demyelinating disorder, whereas Guillain-Barré syndrome and Charcot-Marie are peripheral demyelinating disorders. That is about myelin and its clinical importance. Multiple sclerosis, very important in medicine. Over to axonal transport. Along the axon, how substances are transported by means of anterograde transport and retrograde transport. Antero means the normal direction. From the cell body, any substance synthesized in the cell body is transmitted to the axon terminal. So this is by anterograde transport. Orthodromic means that is the correct direction from cell body to the axon terminal. What are the substances which are transported like this? Whatever is synthesized in the cell body, like neurotransmitters, enzymes and proteins. And kinesin is the protein which is going to help you in this anterograde transport. Very important. Repeat question. Kinesin helps in anterograde transport. Retro means reverse. So if substances are going in reverse direction from the axon terminal into the cell body, this is called retrograde transport. And this is helped by the protein dynein. What are the substances which go in retrograde direction? Rabies virus. If a dog bites you here, so from my hands, it is going to go in the reverse direction. The rabies virus in the saliva travels in the reverse direction and this will attack my spinal cord and brain. So rabies virus. Tetanus toxin. You have any injury with a rusted particle or a dirty particle, the Clostridium tetanus toxin enters into the skin, goes in the reverse direction, attacks your brain and spinal cord. Or you just remember like this, rabies, toxin, viruses, all these are dangerous substances. When all this enters into the body, the patient might die. So dynein, dangerous substances die, carried by dynein. So there was a question on molecular motors. Recently, your FMG paper had this question. What is a molecular motor? Any substance which is going to move another substance. That is a motor. Motor means it should move something else. What are the two molecular motors just now we saw? Kinesin and dynein, because they are moving substances on the axon. So the molecular motors are kinesin and dynein. In muscle, which is the molecular motor in muscle? In muscle, what is the molecular motor called as? Yes, can anybody? Can we type? Excellent, Siddhi. That is called as myosin. Why it is called a molecular motor? Because myosin is going to move the actin. When myosin actin are attached like this, myosin head will go and bind to actin. It will pull the actin. So myosin is going to move actin. So myosin also becomes a molecular motor. Myosin is a molecular motor. So what are the three molecular motors? Repeat question. Kinesin, dynein and myosin are molecular motors. Over to nerve injury. There are two different classifications of nerve injury. Seddon's classification and Sunderland's classification. First we'll do Seddon's classification. According to Seddon's classification of nerve injury, there are three types of nerve injuries. This is a normal neuron. The first one that you see, the first diagram, I've just zoomed in here. This is a normal neuron. The black line that you see in the center is the axon. Around the axon, this blue color covering is the myelin sheath. And over that, you can see the layers, endoneurium and epineurium. Inner endoneurium, outer epineurium. In between endoneurium and epineurium, we have the perineurium. Now, the first image is a normal neuron. Nothing has been damaged. Now, the second one, neuropraxia. So this image, what is neuropraxia? Praxia means disturbance in conduction. So here there is no anatomical injury. Nothing has been cut. Just see this diagram. Nothing has been cut. There's no cut injury there. But only you can see redness. The redness indicates that it has been compressed. It is not cut. It is not injured. It is only compressed. So in neuropraxia, it is a compression injury. Nothing is anatomically cut. No anatomical disruption. So in neuropraxia, it's a compression injury, disturbance in conduction, but anatomically normal. Example, wrist drop or Saturday night palsy or honeymoon palsy. All this is injury to the radial nerve. The other type, axonotmesis. Otmesis means cut. Axonotmesis means axon has been cut. As you can see, the black line has been disrupted here. So the axon has been cut. So this is axonotmesis, where the axon sometimes along with the myelin is cut. Example, nerve crush injuries. This is a moderate form of injury. Neuropraxia is the mildest form of injury. Axonotmesis is a moderate form of injury. The last one, neurotmesis. Otmesis means cut. Neurotmesis means the whole neuron has been cut. The whole nerve has been cut. This is neurotmesis. You can see it is cut. This is the worst form of injury. Transection injuries. Example, spinal cord transection. It has been cut. This is the worst form of injury. What is Sunderland's classification of nerve injury? So till now what we had seen is Seddon's classification of nerve injury. According to Sunderland's classification of nerve injury, so he made it very simple for us. So he says we will call neuropraxia as first degree injury, axonotmesis as second degree injury, and in axonotmesis he says if the axon along with endoneurium is cut, the innermost layer is also damaged, this becomes third degree. And in neurotmesis, if endoneurium plus perineurium is cut, this is called fourth degree injury. And if all three layers are cut, endoneurium plus perineurium plus epineurium, if all three layers are cut, this is fifth degree injury. So according to Sunderland's classification, first degree is the mildest form of injury and fifth degree is the worst form of injury. There was a confusion on this third degree, whether it is axonotmesis or neurotmesis. Now it has been included under axonotmesis only. So third degree comes under axonotmesis only. Next, let's move on to Erlanger and Gasser classification of nerve fibers. So first of all, you should know Why should you classify the nerve fibers? We can have only one type of nerve fiber. Why do you need so many type of nerve fibers? Because they have different functions. Based on the function only, we are classifying the nerve fibers. According to Erlanger-Gasser classification, A alpha, A beta, A gamma, A delta, type B and type C. These are the different types of nerve fibers. And in the class, we had already discussed stories based on this. You remember, you want to buy a car, you go to the motor company, buying a car, touching, all that we had learned. So just I'll tell you the functions here. What are the functions of the Erlanger and Gasser classification of nerve fibers? A alpha. What is the function? They are motor fibers. They help in proprioception. That's why we call them as alpha motor neuron, because they help in motor functions. There are two types of proprioceptors. Proprioception means position sense. It is sensed by the muscles. There are two types of proprioceptors in the muscle spindle and GTO, Golgi tendon organ. So A alpha, motor and proprioception. A beta, touch and pressure. It helps you in touch and pressure. A gamma, intrafusal muscle fibers. A gamma supplies the intrafusal muscle fibers. Intrafusal muscle fibers are fibers which are present inside the muscle spindle. And A delta, cold and fast pain. B fibers, preganglionic autonomic nerves. Type C fibers, postganglionic autonomic, hot sensation and slow pain. All these are carried by the different types of nerve fibers. This is called Erlanger and Gasser classification of nerve fibers. There's another classification called Lloyd's classification. So if you look into Erlanger-Gasser classification, this will include both motor and sensory. It includes both motor and sensory nerves. Motor functions, sensory functions, both are there. But Lloyd's classification, this includes only sensory. So other than the sensory, if you remove the motor and autonomic, it becomes Lloyd's classification. Very simple. In this classification, we will choose only the sensory. A alpha, it is motor, but it also carries proprioception. What is proprioception? Position, sense. It is sensory. So this becomes type 1 Lloyd's. So A alpha is type 1 Lloyd. In proprioceptors, we have two types. Muscle spindle, Golgi tendon organ. So to the muscle spindle, it is called 1A. To the Golgi tendon organ, it is called 1B. A beta, touch and pressure. What is touch and pressure? Sensation, sensory. So this becomes type 2. A gamma, intrafusal muscle fiber. Muscle is not sensory. So I cannot include this. A gamma is not in the Lloyd's classification. A delta, cold and fast pain. Yes, cold and pain both are sensory. So this becomes Lloyd's type 3. B fiber, autonomic. Autonomic is to the organs. It is not sensory. So I cannot include this. Type C, postganglionic autonomic, but it is also hot and pain. Hot and pain are again sensory. So this becomes Lloyd's type 4. Yes. Let me ask you a question now. Just say true or false. Lloyd's classification type 4 is Erlanger classification type C. True or false? Just type T or F. True or false? Just type T and F. I'll repeat. Lloyd's classification type 4 is called Erlanger classification type C. Excellent. Sahana and Dheeraj, very good. That's correct. That's true. That was your repeat question. Lloyd's type 4 is Erlanger type C. Correct. So that is about Erlanger and Gasser classification. Few points about the properties of type A, type B and type C. A is the first alphabet, king of alphabets. So we have to give all importance to A only. A becomes largest, fastest. Why is it fastest? Because it is myelinated. So A fiber, large, fast, myelinated. C fiber, exactly opposite. Smallest, slowest. Why is it slowest? Unmyelinated. Yes, Otto. Yeah, I'll hand it to the admin team. You can take it from them. You can take it from them, doctor. I'll share the PDF with the admin team members. You can collect it from them. Yes. Type B is both. It is in between A and C. It has both the properties. Is that fine, Dr. Otto? Action potential. Very important topic. What is action potential? How impulses are carried inside your body. We said you are able to feel sensations, motor impulses. How are you able to feel all that? Because of electrical impulses carried inside the body. What is this electrical impulse? This is action potential. This electrical impulse is called action potential. So let's see what are the important events in action potential. So in action potential, we have time in milliseconds on x-axis and membrane potential in millivolt on y-axis. So it's a correlation between the voltage changes and the time. You can see it starts with the RMP. RMP is resting membrane potential. Resting membrane potential is because of potassium ions. Very important point. RMP is contributed by potassium ions. See, let's say why RMP is contributed by potassium ions. If this is a classroom and we have doors for boys and doors for girls. When the class is at rest, I am going to close all the boys' door. I am going to open only the girls' door. Only girls' door is open. So the strength of the class will depend on boys or girls. Only girls' door is open. Only girls can move. So the strength will depend on girls only because only girls' door is open. Similarly, in a cell which is at rest, all doors are closed and only potassium door is open. Since only potassium door is open, potassium only can move. Since potassium only can move, RMP depends on potassium. Be helpful. We could add information as yes. It's a PDF, doctor. You can just add information into it as you like. You can make notes on it. Don't worry. Or like, what would you suggest, Dr. Otto? What is your suggestion? I thought I'll share you the annotated PDF because you won't have time to just keep writing it now. Okay, so you want it now, but it will be empty. Is that fine? I can share it to you now, but that would just now I'm filling in now. Yes, okay, just a minute. Yeah, Dr. Otto. Maybe in the first break, I'll share you the PDF. Let's not break the session now. So don't worry. In the first break, I'll share it to you. So we were in action potential. So in action potential curve, so we said RMP is due to potassium ion concentration because at rest only potassium door is open. Now let's stimulate this cell. I'm going to give a current to this cell. If you stimulate any excitable cell, it will go for action potential. So this is the action potential that we see. What are the changes that happened here? So initially you can see a small phase in yellow. This is local potential. Local potential. What is the reason for local potential? Let me come back to this classroom scenario. So in the class, we said there are doors for boys and girls. Now the class has just started. From rest, we have just started. At rest, only girls' door was open. Now when the class has just started, I will open one of the boys' door. And let's say Dr. Dheeraj is there. Dr. Dheeraj enters into the class. Only one of the boys' door and only one boy comes into the class. Boys are like sodium. When only one boy comes into the class, one sodium comes into the glass, sodium is a positive ion. Only one positive ion enters into the cell, you will have a small increase in positivity. A very small increase. Why a small increase? Because only one sodium has come inside. If all sodium had entered, it will go up like this. But this is only one sodium had entered. So a small increase in positivity. That we call it as local potential. So local potential is due to the one sodium ion which entered inside. So one boy came inside or one sodium entered inside. Now Dheeraj who came inside, so he is, let's say all boys are waiting outside the class. They have sent Dheeraj inside the class. They said, Dheeraj, you go attend the class. You tell us how the class is. You just send a message, then all of us will come. If it is fine, we will come. Otherwise, we'll run away like that. So Dheeraj is attending the class. Dheeraj finds many beautiful girls in the class. So what is he doing? He is messaging in the group, all boys, please come inside. So one boy who came inside is stimulating all other boys to come inside. This is a positive feedback mechanism. That we call it as Hodgkin's cycle. Entry of one sodium opens all other sodium channels. Entry of one boy has stimulated all boys to come inside. So now what happens? Dheeraj is opening all the boys' door and suddenly all boys are coming inside. Boys are like sodium. So suddenly all sodium entering inside. Na plus, Na plus, Na plus. Suddenly, if you have so many sodium ions coming inside, that is called sodium influx. So much of positivity coming inside, action potential will go like this. Because positive ions are rushing inside, it goes towards positivity. And this we call it as depolarization. Depolarization. What is the reason for depolarization? Sodium influx. Suddenly, so many sodium ions came inside. Now the class is full because all boys have come inside. The class is full. There's no space inside. I'm going to send some students out. If I ask you to go out, who will go out easily, boys or girls? Boys will not go because beautiful girls are inside the class. So girls are going to move now. Girls are like potassium. Girls are going to move. See why in a cell it is more easy for potassium to move out. Can you tell me why it is easy for potassium to go out? See, sodium is not going out. Potassium is going because of the gradient. Very good. Because of the gradient. Potassium is generally more inside and less outside. Because of this electrical gradient, it is more inside, less outside. So it goes from high to low. Potassium easily moves out. When potassium goes out, potassium is a positive ion. If a positive ion goes out, inside becomes negative. So this is returning back to negativity. It is returning back to negativity. So I call it as repolarization. It is getting repolarized. The reason is potassium efflux. Potassium efflux. All this started at RMP, so it should stop at RMP, but it is not stopping at RMP. It is going even beyond RMP. It is going beyond. So that is called hyperpolarization. Hyperpolarization. What is hyperpolarization due to? Potassium ions are moving out. That is potassium efflux. But even after reaching the polarized state RMP, there is some leaky potassium channels which will keep leaking potassium. So they are called slow leaky potassium channels. Yes, exactly, Dheeraj. Local potential is the threshold stimulus. Yes. Once local potential reaches the threshold only, it will be converted into action potential. So this point, very good Dheeraj, this point is called as threshold point or firing point. Only when local potential reaches the threshold or firing, it will be converted into an action potential. So these channels, sodium influx and potassium influx, are due to voltage gated channels because they are opening and closing in response to voltage. So we call them as voltage gated sodium channel and voltage gated potassium channels. They are controlled by voltage. But hyperpolarization is due to This is not voltage gated channel. This is a slow leaky channel. It will always be open. Slow leaky potassium channels. So the possible questions that can be asked from action potential: depolarization due to dash sodium influx, repolarization due to dash potassium efflux, hyperpolarization due to slow leaky potassium channels, RMP is due to potassium ions, local potential due to one sodium or few sodium. So this is about action potential curve, and these are the possible questions that can be asked from the curve. It's over to equilibrium potential. How would you calculate equilibrium potential? By Nernst equation. Nernst equation. What is Nernst equilibrium? The equilibrium potential of any ion is equal to plus or minus 61 into log of C1 by C2. C1 and C2 are concentration of the substance in one compartment divided by the other compartment. What are the two compartments here? One is inside the cell, ICF, other is outside the cell, ECF. So since we are placing plus or minus, you can put it as ICF by ECF or ECF by ICF. Both are correct, because anyway the sign doesn't matter because you have plus or minus there. So it could be ECF by ICF or ICF by ECF. So that is the Nernst equation. According to Nernst equation, yes, there is a question there. Oh, just a minute, Siddhi. I'm just trying to open that. Yes. See, there's a good question. At the end of repolarization, the nerve is hyperpolarized. Yes. How does the membrane return back to RMP? See, how does the membrane return back to RMP? We have sodium potassium ATPase pump. What is the function of sodium potassium ATPase pump? So this pump, sodium potassium ATPase pump, the function is it will send out sodium. In exchange, it will take in potassium. This is the function of this pump. Just understand what has happened at the end of action potential. After all this, sodium came inside, potassium has gone outside. Sodium influx, potassium efflux. Sodium came inside, potassium has gone outside. So I'll write that sodium had come inside and potassium had gone outside. So at the end of action potential, sodium is inside, potassium is outside. So who will bring it back to normal? Sodium potassium ATPase pump. What is the role of sodium potassium ATPase pump? It will send out this sodium and it will take in this potassium. It will send out the sodium and it takes in the potassium. So again the cell will be restored back. Normally in a cell, potassium should be more inside, sodium should be more outside. But at the end of action potential, it has become ulta. It is reversed. Completely it is reversed. What has happened? All sodium came inside, potassium went outside. So how will you restore the cell back to normal? Sodium potassium ATPase, which is going to send out all the sodium, take in all the potassium. Yes, Dr. Siddhi, the answer would be action of sodium potassium ATPase pump. Got it, Siddhi? Yes. So this is no. The correct answer is sodium potassium ATPase pump. Pump only is the right answer. Nernst equation. The equilibrium potential is plus or minus 61 into log of C1 divided by C2. So that's just a formula. Yes. Over to general physiology. We're done with the nerve physiology. We'll move on to general physiology. In general physiology, transport across the cell membrane. This is a very important topic in general physiology. So I think we have general physiology topics coming behind also. Just a minute. Okay. So just I'll tell you the differences between active and passive transport. What is active and what is passive type of transport? Very, very important topic. A small topic, but a high yield topic. So let's learn this with the help of a mountain. Let's say there is a mountain there and we have Dr. Siddhi. So Siddhi wants to climb this mountain. Now, how will Siddhi climb this mountain? Siddhi has to go from low to high. You're going from low concentration to high concentration. It is against the gradient. So you have to go against the concentration gradient. Do you need energy for this? Yes, you need energy. Need energy. And you have to climb actively. This is called active transport. What is Siddhi's primary source of energy? Your own ATP. If you break your own ATP and get your own primary source of energy, that is primary active transport. So all ATPases, they are primary active transport. Sodium, potassium ATPase, the calcium ATPase, hydrogen, potassium, proton pump. Anywhere there is ATP broken, ATPases are primary active transport. Then what is secondary active transport? Let's say there is Siddhi's friend who's already climbing the mountain. Now Siddhi wants to climb the mountain, but you don't want to waste your primary energy. So you're just climbing on top of your friend and your friend is going to carry you now. Now both of you are going against the gradient. Both of you require energy, but it is not Siddhi's primary ATP. It is the friend's energy. Most of the time, if you use your friend's energy, somebody else's energy. So it is called secondary active transport. Most of the time, the friend is sodium only. Along with sodium, secondarily, if any substance is transported, this is called secondary active transport. Example, SGLT, sodium glucose co-transporter, SGLT, excellent. Sumonil Guha, very good. NKCC, sodium potassium chloride channel. NIS, sodium iodide symporter. So all these are secondary active transporters. Yes, Dhananjay Singh, yes. So these are all secondary active transporters. In secondary transport, there are two types. If sodium and the substance both go in same direction, now all these are called as symporter or co-transporter. Symporter or co-transporter. They go in the same direction. When both the substance go in opposite direction, sodium is going inside, the other is going outside. If they go in opposite directions, it is a counter transporter or antiporter, counter transporter or antiporter. Example, sodium calcium exchanger, sodium hydrogen exchanger. All exchangers are counter transporter or anti-transporters. So in transport across the cell membrane, we have seen active transport, two types. Primary means ATPase, secondary means along with sodium. If they go in same direction, symporter, opposite direction, antiport. Now, what is passive type of transport? Now, let's say Dr. Siddhi is already on top of the mountain. Siddhi just wants to come down. Do you need energy for this? You're coming from high to low. So, when you come along the gradient, along the concentration gradient from high to low, you don't need energy. No need of energy. This is called passive transport. There are different types of passive transport. Simple diffusion, facilitated diffusion. Simple diffusion is Siddhi is just lying down there like a sliding board. Siddhi is sliding and coming down. You are not using anybody's energy. Nobody is carrying you. Just you slide and come down like that. Simply you come down. This is called simple type of diffusion. Who will do this? Oxygen and carbon dioxide. Across the respiratory membrane, there are no carriers for oxygen and carbon dioxide. They'll just simply go across the membrane. Facilitated diffusion. Facilitated means somebody is going to facilitate. Someone is going to help you. You have a carrier protein which will help you. Now let's say there is a bus on top. Now Siddhi is going to come through this bus. A bus can hold a maximum of, let's say, 50 people. If Siddhi is the 51st member on the queue, there's no place. So it has already reached the T max. So what is the problem with the carrier protein facilitated diffusion? It can hold only so much, only maximum. It has a T max. Once if already 50 people are there into the bus, there's no place for you. You can't come down. It stops. Saturation. It will saturate. So Tmax and saturation are followed by facilitated diffusion, a carrier protein. Until the carrier protein is there, it will carry you. If it is exhausted, you can't come down. Example, GLUT transporter, GLUT. This will carry only glucose. Remember the difference between SGLT and GLUT. SGLT is sodium along with glucose. It is secondary active transporter. GLUT is only glucose. This is a facilitated diffusion. Repeat question. Yes, excellent, Dheeraj. Osmosis. The other type of passive transport is osmosis. Osmosis is for movement of water. Water can go simply across the membrane or it can use water channels called aquaporins. So this is about active and passive type of transport. Yes, over to neurophysiology. In neurophysiology, first let's do the sensory tracts, then we'll do the motor tracts. What are all the sensory tracts? See, first of all, you understand that all sensations, if someone is touching me here, how this sensation is carried into my brain? Through the sensory tracts. So sensory tracts will always go up. From the skin, they'll go up into the brain. So all sensory tracts are ascending tracts because they are ascending on top. Motor. Motor means you have to move your muscle. See, I'm moving my hands now. Who is telling me to move this muscle? My brain is telling me. So only from the brain, impulses will come down to the muscle. So the motor tracts are all coming down. They are all descending tracts. All ascending tracts are sensory tracts. All descending tracts are motor tracts. First, let's do ascending or sensory tracts. What are all the sensory tracts? Yes, anybody, can you type? What are all the sensory tracts that you know? Yes, can you name any sensory tract you know? Very good. Swanel, dorsal column spinothalamic tract. Yes, exactly. Dorsal column carries all these sensations. What are the sensations carried by dorsal column? Fine touch, vibration, proprioception, joint position sense, tactile localization, two-point discrimination, stereognosis, and graphesthesia. All this is carried by dorsal column. Let me trace the dorsal column pathway from one half of the body. Dorsal column fibers. I'll trace it in pink color. They start, they go into the spinal cord, they go up into the medulla, they cross in the medulla to the opposite side to reach the thalamus and the sensory cortex. So where does the dorsal column fibers cross? They cross only in the medulla. Very, very important point. Dorsal column crosses in the medulla. What about the other one? Spinothalamic tract. Spinothalamic tract is of two types. Spinothalamic tract is of two types. Anterior spinothalamic tract and lateral spinothalamic tracts. Anterior spinothalamic tract carries crude touch, itching and pressure. Lateral spinothalamic tract carries pain and temperature. That is why sometimes together we call it as anterolateral spinothalamic tracts. Let's trace the spinothalamic tract, the pathway. So this starts from one half of the body, goes into the spinal cord. Spinothalamic. Spino means they cross in the spinal cord itself. That's why spino. So they cross in the same segment of the spinal cord itself to the opposite side and they ascend up into the sensory cortex. That is why it is called spinothalamic. Crosses in the spinal cord itself, goes through the thalamus. So very important. Dorsal column crosses in the medulla, whereas spinothalamic tracts cross in the spinal cord itself to the other side. See, that is why, listen carefully, if there is any damage to the dorsal column fibers, let's say this is the left half of the body and this is right side. if there is any damage to the left half of the dorsal column tracts, on the left half of the body, patient will lose dorsal column sensation. Same side, ipsilateral. If there's any damage to this dorsal column fiber, because from spinal cord to medulla only, they are exactly called as dorsal column tracts. They cross in the medulla. After crossing, they become the middle lemniscal pathway. So exactly from spinal cord to medulla, they are called dorsal column tracts. If this is damaged, on the same half of the body, patient will lose dorsal column sensation. What about spinothalamic tracts? If right side spinothalamic tracts are damaged, left half of the body, patient will lose sensation. Pain and temperature will be lost on the opposite half. This is contralateral, opposite side. Dorsal column is damaged, same side there is a defect, ipsilateral. Spinothalamic tracts are damaged, contralateral. Opposite side there is a defect. Very, very important point. So that is about the ascending or the sensory tracts. As you can see, both the sensory tracts pass through the thalamus. So thalamus is called sensory relay station because all sensations are relayed into the thalamus. So this is the thalamus. Let's see the different nucleus of thalamus quickly. Since we are coming across thalamus, I'll finish thalamus also. Thalamus is called sensory relay station. All sensations are relayed through the thalamus except one, olfaction. Smell does not go to thalamus. Except olfaction, all other sensations are passed through the thalamus. What are the other nucleus of the thalamus and their functions? Anterior nucleus. I'll tell you one easy way to remember this. Listen carefully. Anterior nucleus of thalamus. Thalamus carries all sensations. Emotion is also a sensation. Of all sensations, we always show emotions only in front. Yes, you put emotions only in front. So put emotions in the front nucleus. Anterior nucleus, emotions. Emotions are related to memory. Memory is related to learning. So anterior nucleus, emotions, memory and learning. VPL and VPM. Ventero-posterolateral and ventero-posteromedial. That is VPM, VPL. How do you remember this? L for limbs. All sensation from limb is carried into VPL, lateral. M for mouth. So all sensation from mouth is carried to medial. So limbs, lateral nucleus, mouth, medial nucleus. Mouth is on the face. So mouth and the face goes to medial nucleus. Yes, now can you answer me this? Taste pathway is carried through which nucleus of thalamus? Yes, I want all of you to answer. Taste pathway is only if you answer, it will be a two-way session. Otherwise, it will be very boring. You will sleep off. Yes, just type something. Why am I asking you to type something? Even if you feel sleepy, you do that, you will be alert. That's why. So please contribute. Excellent, all of you. VPM. Because taste is from the mouth. Yes, we have newcomers. Kiran Yadav. Nice. Nice to see some new members answering. Kiran Yadav. Soonil, all old members. I want new members also to answer. Agrima Yadav. Which nucleus is responsible for hunger? Hunger nucleus is not in the thalamus, doctor. It is in the hypothalamus. Lateral nucleus of hypothalamus has the hunger center. Okay. That's not thalamus. That is hypothalamus. Yes. This is about the thalamus. VL and VA are called motor nucleus. This is not a very important function of thalamus. Insignificant because thalamus is sensory only. But still, ventral anterior, ventral lateral carries motor. Medial geniculate body and lateral geniculate body. Medial geniculate body, M for music. You hear music. So hearing pathway, auditory pathway goes to medial geniculate body. Lateral geniculate body, L for looking. Looking means you look with your eyes, vision. So visual pathway goes to lateral geniculate body. M for music, L for looking, vision. Nearby the anterior nucleus, there is a thalamic reticular formation. What is the function of thalamic reticular formation? It has no specific function. It will coordinate all other nucleus. It is just coordinating all other nucleus. Coordinator. And one special point is that this one will produce inhibitory neurotransmitter GABA. Because all other nucleus of thalamus produces glutamate, excitatory neurotransmitter, and only this thalamic reticular formation produces GABA, the inhibitory neurotransmitter. Yes, this is about the different nucleus present in the thalamus and their functions. So all the sensations, after passing through the thalamus, they reach the sensory cortex. Which part of the brain is called sensory cortex? Repeat question. Can you give me the Broadman number? Yes, anybody give me the Broadman number areas for sensory cortex? Excellent, Sunil. 3, 2, 1. Very good. And also 5 and 7. 3, 1, 2, or just remember like this. 1, 2, 3, 5 and 7. So I'll just show you the sensory cortex. If this is the central sulcus, excellent Siddhi. If this is the central sulcus will divide the brain into front side and behind. So you in front of the central sulcus, you have frontal lobe. So in front of the central sulcus, this is the frontal lobe. What is the function of frontal lobe? Mainly motor in function. So we have Broadman numbers 4 and 6. Behind the central sulcus, if this is central sulcus, front is frontal lobe. That's why it's called frontal. It's in the front. Behind the central sulcus, this is the parietal lobe. Parietal is mainly for sensory. And Broadman numbers 1, 2, 3, 5 and 7. So if you arrange from 1 to 7, the two missing numbers are 4 and 6. So when you arrange from 1 to 7, 1, 2, 3, 5 and 7 are sensory. The two missing numbers 4 and 6 will belong to the motor. So 1, 2, 3, 5, 7 sensory. 4 and 6 missing numbers motor. When all these sensations touch your sensory cortex, you are able to feel the sensations. So if there's any damage to the parietal cortex, your sensations will be affected. You'll have a sensory defect. It's back to the dorsal column. So dorsal column and spinothalamic tracts are the two sensory tracts. Let's discuss little more about the dorsal column tract and the spinothalamic tract. First, the dorsal column pathway. Let me trace the dorsal column pathway. So from one half of the body, they carry sensations, go into the spinal cord. And from spinal cord, they go up to medulla, cross in the medulla to the opposite side like this. This is the dorsal column pathway. When they go from spinal cord to medulla, they go as two separate tracks like this. You can see a pink one and the blue one. So this pink one, this is called as fasciculus gracilis. And this blue one is fasciculus cuneatus. Fasciculus gracilis, fasciculus cuneatus. Fasciculus gracilis. I'll tell you 2 points about fasciculus gracilis. You just remember the muscle gracilis. Where is gracilis muscle located? Yes, can you tell me where is gracilis? Gracilis is a medial muscle of the legs, lower limb. It is located on the middle part of your thigh. Excellent, Siddhi, medial thighs. See, listen to this. Gracilis is located in the medial part of your lower limbs. Similarly, fasciculus gracilis runs medially, carrying sensation from lower limb. Two words. Gracilis runs medially. Gracilis is a muscle located medially on the lower limb. Two words. Fasciculus gracilis also runs medially, carries sensation from lower limb. Medially means towards the center, more towards the spinal cord, inside. What about cuneatus? Exactly opposite. Fasciculus cuneatus will run laterally, carrying sensation from upper limb. Laterally means away from the spinal cord. Runs laterally, carrying sensation from upper limbs. So this is the dorsal column. Two tracks in dorsal column, fasciculus gracilis and fasciculus cuneatus. After crossing in the medulla, now you label them as medial lemniscal pathway. Medial lemniscal pathway. After crossing in the medulla, they are called as medial lemniscal system. They enter through the thalamus into the sensory cortex. That is about the dorsal column fibers. Next, the pain pathways, spinothalamic tract. So we have finished one of the sensory tract, dorsal column. The second one is spinothalamic tracts, which carries pain and temperature, but pain is more important. So pain pathways, we'll discuss this as pain pathways. What are the two type of pain pathways? Can you recollect Erlanger and Gassler classification? What are the two fibers which will carry pain? Fast pain A delta, slow pain C fibers. So two fibers which carry pain A delta and C. Excellent. Sonal, A delta and C. Very good. That is why we have two type of pain pathways. A delta pathway, C pathway. So which is faster now? A. So A delta pathway carries fast pain, sharp pain or epicritic pain. That's called the first pain. What is the example for sharp pain? A needle prick injury, electric shock injuries. All these are sharp pains. When we trace the A delta pathway, let me trace the A delta pathway. Just see this. A delta pathway goes into the spinal cord. It's a spinothalamic tract. So it will cross in the spinal cord to the opposite side. It will go up like this. This is the A delta pathway. But you can see that it is not giving any diffuse connection within the midbrain pons and medulla. It's a direct pathway. It's a very specific localized pathway. It starts here and it ends there. That's all. It is not giving any diffuse connection. That is why it is a specific localized pathway. Since the pathway is very specific and localized, the pain is also very specific and localized. What is the example for localized pain? Needle prick injury. If a needle pricks you in your finger, only here locally it will pain. You will not have pain in any other part of the body. Since it is a localized pain, only one area is paining, one neurotransmitter glutamate is enough. Faster pathway. Fast means new. So it is called neospinothalamic tract. Now let's do the C fiber, C pathway. The C pathway, C fibers are slow. So they are slow pain and dull pain, also called protopathic pain or second pain. What is the example for slow pain? Visceral pain. Any pain that comes from inside the viscera. It is a diffuse pain. Why it is called as a diffuse pain? Because if you look at the pathway, I'll just trace the pathway of C fibers. This is the C pathway. Just look at this. They go into the spinal cord. They cross to the opposite side like this. And when they ascend through the midbrain pons and medulla, they give multiple branches like this. So you can see diffuse multiple branching pattern you can see. They are giving diffuse connections in the midbrain pons and medulla. The pathway itself is very diffuse. That is why the pain carried by them is also diffuse. It means if you have a visceral pain, for example, a renal stone pain, a renal colic pain, you cannot point out and say only here my abdomen is paining. You won't know where it is paining. Have you experienced a stomach pain? In general, we say stomach pain, but you can't point out and say. You don't know where it is paining. It is very diffuse. Why it is very diffuse? Because the pathway itself is very diffuse. That is why the pain is also very diffuse. Since the pain is very diffuse, it has to go to many areas. One neurotransmitter is not enough. Glutamate is not enough. You need one more neurotransmitter, that is substance P. This pathway is slower. Slow means older. Older is called paleo. So this is called paleospinothalamic tracts. Paleospinothalamic tracts. So these are the two different types of pain pathways, A delta pathway and the C pathway. So that is about the sensory nervous system. Excellent, Ranjan. Fasciculus cuneatus laterally from upper limb. Good. So now we will move on to descending tracts or motor pathways. Yes, let me just know in the chat box. If the pacing is fine for you, is it too slow or too fast, or language or anything you want change, or shall we go ahead like this? Do you want any changes, or this is fine? Shall we move on like this? Yes. Thank you. Thank you. Thank you. Yeah, we have a newcomer on the chat box. Pranjali. Pranjali. Good. Kush. Yes. Yes. We have a query from medial lemniscus. What is that? What is it, Dr. Ranjan? Medial lemniscus? Medial lemniscus are the crossed fibers. After crossing in the medulla, they form the medial lemniscus. See, medial lemniscus is not from upper or lower limb. Okay, so this is confusing for you. So I'll put in a different color. Medial lemniscus, after crossing, the fibers are called as medial lemniscus. Both fasciculus gracilis, fasciculus cuneatus, both the fibers will cross. Yes, both of them will cross. Yes, now is it fine? Both of them will cross. Both together, after crossing, we call them as medial lemniscus. See, medial lemniscus will mainly carry from your face. Kiran Yadav says a bit slow. Okay, fine, doctor. We'll go a bit slower. So, Ranjan, after crossing, it's the medial lemniscal pathway. Medial lemniscal pathway, the face fibers join the medial lemniscal pathway. So, after crossing from the face, they will carry the sensations. Fine. Next, let's move on to the descending tracts or the motor tracts. There are two types of descending or motor tracts. Lateral descending tracts. Lateral means away from the spinal cord. They will descend laterally like this to supply lateral muscles of the body. Lateral muscles are the limb muscles or the distal muscles. What are the lateral descending tracts? Lateral corticospinal tract and rubrospinal tract. Lateral corticospinal tracts and rubrospinal tracts. What is the function of lateral corticospinal tract? Listen, they descend laterally. Laterally means away from the body, away from the center, to supply lateral muscles of the body. Lateral muscles are my finger muscles, distal muscles. What do I do with my finger muscles? Fine voluntary movement. So the function is it helps in fine voluntary movement. Rubrospinal tracts. Oh, Kiran, I'm sorry. You said move little faster. Okay, okay, got it, got it. Yes, little faster. Okay, fine. Lateral corticospinal tracts, they are responsible for fine voluntary movements. Rubrospinal tract. Rubro means red nucleus. This starts from the red nucleus, and this has a function of causing flexion of the upper limb. See, flexion only of the upper limb, because rubrospinal tract ends at the level of cervical cord itself. Below the cervical cord, you don't have rubrospinal tract. It ends at cervical cord itself. Cervical cord is the supply only to the upper limb. So rubrospinal tract supplies only the upper limb. See, if I flex my upper limb like this, that's a voluntary movement. Is exactly Ranjan and Sonil. So this also helps in voluntary movement. So we see that both the lateral descending tracts help you in voluntary movement. Medial descending tracts. They descend medially like this in the center. Medially means there are four descending tracts. They are medial corticospinal tract, tectospinal tract, vestibulospinal tract, and reticulospinal tract. Medial corticospinal tract. Corticospinal is motor. Medially means to supply medial muscles of the body. What are the medial muscles of the body? Trunk muscle. If I move my trunk muscle, yes, see, I'm moving my trunk muscle, I can change my posture. So this helps in posture control. Tectospinal. Tectum is located in the midbrain. Tectum is related to eyeball movement. If you maintain your eyeball movement, you can maintain your posture. Vestibulospinal is related to vestibular apparatus. Vestibular apparatus helps in balance. Yes, again posture. Reticulospinal, this can cause extension of all four limbs. Rubrospinal, flexion only of the upper limb. Reticulospinal, extension of all four limbs. So if I extend all four limbs like this, that is also a posture. So this also helps in posture regulation. Yes, we have another newcomer, Hadia Syed. Welcome to the chat box. So these are all the functions of the medial descending tract. So we see that all the medial descending tracts help us in posture regulation. So to summarize, lateral descending tracts help you in voluntary movement. Medial descending tracts help you in posture regulation. So these are the two functions of the descending or the motor tracts. Yes, let's discuss corticospinal tract in detail. Anatomy also is very important. Corticospinal tracts. Cortico means it starts from the motor cortex. This is the motor cortex, especially bed cells of the motor cortex. We say corticospinal tract is a motor tract, but all of this tract will not start from the motor cortex. Only 60% starts from the motor cortex. Remaining 40% starts from sensory cortex. Even though corticospinal tract is a motor tract, 40% comes from sensory cortex also, because you need your sensations also for maintaining movement. Now this motor cortex, the pathway descends down into the internal capsule, especially posterior limb of internal capsule, midbrain, pons and medulla. And at the level of medulla, maximum fibers cross to the opposite side. They are crossing to the opposite side. How much of fibers will cross like this? 80 to 90% of the fibers cross in the medulla to the opposite side. Now after crossing, they are actually crossing through pyramid shaped structures in the medulla. Medulla has pyramid shaped structure. Since they are crossing through the pyramids, we call these fibers as pyramidal tract. So they are called the pyramidal tract or the lateral corticospinal tracts, which will supply the opposite half of the body. So they will descend down like this to supply the opposite half of the body. See, when they descend down into this spinal cord, they will descend into the anterior part of the spinal cord, because according to Bell-Megendie law, dorsal, when you write dorsal, S for sensory. Dorsal means backside. Dorsal side will carry only sensory neurons, and ventral or anterior side will carry motor neurons. So that is why, excellent Ranjan, they will all end up in the ventral side or the anterior side. Since they come to the anterior side, they end on anterior horn cells. So these are called as anterior horn cells. From the anterior horn cells, we have two type of nerve fibers arising, A alpha and A gamma. What is the role of A alpha and A gamma? They are going to supply your muscles, and they'll contract the muscle, thereby you're able to do a motor movement. So this is how the course of corticospinal tract. So when we say these fibers end on anterior horn cell, all the fibers will not end on anterior horn cell. Only 30% of these fibers will end on anterior horn cell. The remaining 70% of the fibers, they end on inhibitory interneurons. Inhibitory interneurons. What is inhibitory interneuron? It will do inhibition. So, maximum corticospinal tracts are doing inhibition only. Only 30% is going for contraction. Remember this point. The main function of corticospinal tract is inhibitory only. There are two different terms here, UMN and LMN. UMN means upper motor neuron. Neurons which are up are called upper motor neurons. Up means from brain to spinal cord, UMN. Spinal cord to muscle, LMN. So which is the major UMN that you see here? Upper motor neurons. Yes, the green one is corticospinal tract or pyramidal tract. So corticospinal tract or pyramidal tract is the major upper motor neuron. Lower motor neuron is from spinal cord to muscles. It means anterior horn cell, A alpha and A gamma. They are lower motor neurons. If there is any damage to the upper motor neurons, it is called as UMN lesion. If there's any damage to lower motor neuron, it is called as LMN lesion. Now, Which is the most common site of injury to this corticospinal tract? Internal capsule. Internal capsule. Because the superior half of the internal capsule is supplied by lenticulostriate branch of middle cerebral artery. This is called as Charcot's artery. Charcot's artery. The superior half of internal capsule supplied by lenticulostriate branch of middle cerebral artery, and damage to this artery is the most common cause of hemiplegia. Most common cause of hemiplegia. So what are the other lesions in this tract? At the level of midbrain, pons and medulla, if these fibers are damaged, there are different syndromes related to this. At the level of midbrain, pons and medulla, so just imagine if this half of the fiber is damaged, on the opposite half patient will have hemiplegia. This is called contralateral hemiplegia. So in all the lesions, if you see, there will be contralateral hemiplegia along with a cranial nerve palsy, because cranial nerve nucleus are located in the midbrain, pons and medulla. So let's see what are the diseases. For example, if there is any damage to this fiber at the level of midbrain, excellent. Midbrain, it is called Weber syndrome. Weber syndrome. At the level of midbrain, we have the third nerve nucleus, oculomotor nerve nucleus. So what is the presentation of Weber syndrome? Contralateral hemiplegia. Opposite side, you'll have hemiplegia plus ipsilateral third nerve palsy. Because cranial nerves do not cross. Only the corticospinal tracts will cross. So it will cause same side third nerve palsy. Opposite side contralateral hemiplegia, and same side. You want me to repeat this? Yes. So I'll repeat, please listen. If there is any damage to these fibers at the level of midbrain, pons or spinal cord, the patient is always going to have a contralateral hemiplegia. Because if this side of the fiber is damaged, opposite side he is going to have hemiplegia. So it's always contralateral hemiplegia. But cranial nerve nucleus, they don't cross. So cranial nerves will be affected on the same side. Cranial nerve nucleus are located inside midbrain, pons and medulla. If there is any damage to the midbrain has third nerve, oculomotor nerve nucleus. So the patient will present with contralateral hemiplegia, ipsilateral third nerve palsy. Yes. Next, at the level of pons, if there is any damage at the level of pons, Raymond syndrome. Raymond syndrome. In Raymond syndrome, contralateral hemiplegia plus ipsilateral sixth nerve palsy, because sixth nerve nucleus is located in the pons. Sixth nerve is abducens nerve. At the level of pons only, Fovili and Millard-Gubler syndrome. Fovili and Millard-Gubler syndrome. At the level of pons only, we have seventh nerve also. So this causes contralateral hemiplegia plus ipsilateral sixth nerve plus seventh nerve palsy. Only sixth nerve palsy Raymond, sixth and seventh nerve palsy Fovili, Millard-Gubler. Now, at the level of medulla, if there is any damage to these fibers, at the level of medulla, Dejerine syndrome. Dejerine syndrome. Medulla has 12th nerve nucleus, hypoglossal nerve. So this is contralateral hemiplegia plus ipsilateral 12th nerve palsy. 12th nerve is hypoglossal nerve. So all these are repeat questions, especially Weber is a many time asked question. So these are all the different type of syndromes associated with the corticospinal tracts. We said 80 to 90% of the fibers cross to the opposite side. What about the remaining 10 to 20% of the fiber which did not cross? So this will descend on the same side. The uncrossed fibers, so they will descend on the same side. And they are called as medial corticospinal tracts. The remaining 10 to 20% which did not cross, they form medial or ventral or anterior corticospinal tracts. Okay, so that is about the corticospinal tracts. A word about UMN and LMN lesion. Example for UMN and LMN lesion. We already know upper motor neuron means corticospinal tracts. So any corticospinal tract lesion or pyramidal tract lesion or hemiplegia is an example for UMN. What is the clinical feature in UMN? Upper motor neuron lesion, three things will be up. What is up? Tone is up. That's called hypertonia. Reflexes are up. That's called hyperreflexia. And toes go up. Babinski sign positive. Excellent, Ranjan. Babinski positive. Lower motor neuron lesion. Lower motor neuron means from spinal cord to muscles. They are the element. So what is the, so they are mainly muscle disorders. Poliomyelitis, spinal muscular dystrophy. So lower motor neuron lesion, three things are low. What is low? Tone is low, hypotonia. Reflexes are low, hyporeflexia. Toes go low. Babinski sign negative. So this is about the differences between UMN and LMN type of lesions. Is over to neuromuscular junction. Neuromuscular junction is a bigger topic. So I think let's have a small break. Yes, let's have a 10-minute break. And after 10 minutes, we'll join back for the neuromuscular junction. Yes, please don't go very far away. Just stay there. Maybe you can scroll in your mobiles, check some WhatsApp notification and some reels. So meanwhile, we'll take a short break. Yes, I'll just announce here. Short break of 10 minutes, or we'll join back at, yes, 15 minutes, 11:40 a.m. So we'll join back at 11:40. Thank you. Yes, I agree, Ma. Both UMN and LMN is amyotrophic lateral sclerosis. Very good. Pranjali also, very good. The disease that affects both UMN and LMN is amyotrophic lateral sclerosis. Stephen Hawking was affected by this disease. Thank you. Please have your break.